to our next speaker, Dr. Vatsal Parikh, who's again a very prolific vitreoretina surgeon from Mumbai, and he heads the Drishti Eye and Retina Center and Rajvi Nursing Home. So look forward to hearing a lot from him. On to you, Dr. Vatsal.
Yeah. Good evening, Dr. Chitra and respected panelists. Can you hear me? Yeah, please. Good evening. Today, I'm going to share my experience with this machine which we have acquired 2 years back. That is image guided ultraviolet field swept source OCT, its clinical applications, and what I feel it could be the future and how it could be helpful in future to come. Now, I do not have any financial interest in this machine, nor any of the presentation what I'm showing. It's basically a multimodal imaging with ultra wide field view that's about 200-degree and single view. And it's a swept source ultra wide field OCT. You can do probably anywhere in the retina up to equator and beyond equator sometimes. And I feel it's an useful adjunct in retinal armamentarium. I'm going to show you some of the patients where we find it to be useful. Now, this is a macular hole which is about 1000 microns. I did vitrectomy with ILM stuffing and SF6 gas. This is 3 hours post-op. You can see that probably the hole is getting close. But 1 day post-op, we could definitely see the hole through the eyes gas fill. OCT was of good quality. And 1 week later, when the gas bubble has gone above the macula, you can see that the hole is closed. So I think this should help us in monitoring the post-op positioning of the patient, especially when you can do OCT through the gas bubble. Now, this is a patient who had lattice degeneration. As you see here, we could do OCT through the lattice. Normally, we read in textbook that lattice shows retinal thinning, which we see very often in our patients. But this patient had retinoschisis-like appearance, though he had lattice degeneration. This is a white without pressure picture, and OCT shown through that area shows schisis-like picture through the white without pressure. Now, this is an interesting patient. His father, he's a young boy who is high myopic. Father both had giant retinal tear operated by me. On family screening, it looked like a horseshoe tear here, but we were fortunate that we could do OCT through this particular thing at ora serrata, and it shows an enclosed dentate process, and we have reported this case in a journal. Now, this patient had post-vitrectomy detachment, and you can see on ultra-wide field photography that there are retinal holes, and OCT done through that area, as you see, confirms the hole. The beauty of this machine, I think, is compared to indirect ophthalmoscopy or slit lamp biomicroscopy, this machine gives better contrast image, so holes can be identified easily, and we were fortunate to able to do OCT through that. So I did cryopaxy and topped up the gas by putting additional C3 effect injection and gave prone position to the patient. The retina settled. However, after 5 days, there was a redetachment which was increasing, and though clinically the photograph doesn't show PVR, I thought this was related to PVR process. And serial photography showed that there was fixed fold appearing. At this juncture, clinically, I thought that the membrane is mature and we could do OCT through that area, and it showed the age of the membrane. And it helped us in operating this patient, and post of the retina is nicely attached and there's silicone oil in the eye. Similarly, OCT done through the macula progressively showed that there are corrugated folds because of the hydration line, and a smooth counter is gone because of the ERM. And on OCT, we could determine where the ERM was, and that helped in operating. And once the retina settles, the corrugated appearance disappears. And probably this being swept source OCT will be able to assess the nature of external limiting zone and PL and monitor visual acuity. We have found it to be useful in retinitis patient also. This is a patient of toxoplasma retinitis, and you can see that there is a retinal involvement here, and with treatment, the retinal involvement is becoming less. However, this is also apparent on clinical examination, so this would be a useful adjunct for the treatment. But this patient, there was a whitish lesion here, and when you see OCT done through that area, it shows that mainly it's the vitreous haze and there's little amount of retinitis. So I think it has a role in uveitis patient also. Similarly, this is a patient of scleritis. You can see that this area is elevated. There was a T sign, and we treated this patient, and the contour came to normal. An interesting observation was in disease that you can see this is a crystal clump here. OCT done through that area showed abnormal vitreoretinal adhesion. So I think this will help us to uncover pathology which we are not seeing till now. I believe this has a role in measuring choroidal thickness and retinal thickness starting from optic disc to the periphery. And as you see in this photograph, the thickness keep on decreasing, and we should be able to work this in different age groups and different refractive status. And this being swept so quality good image. Now this was a patient with amelanotic nevus here, and you can see that the OCT done through that area shows the picture. You can probably have a role of this in tumors, probably up to equator. You can do the OCT. It showed hyperfluorescence. ICG showed again hyperfluorescence here, and FFA showed mild staining in this region. Now this patient has a macular hole and a peripheral retinal tear. Now, clinically, we had missed this tear because, as I told you, that contrast is more with this machine. So, diagnosing tear was easier on the photograph. Clinically, it was missed, and OCT done through the tear shows that there is a also tear here. Now, this patient had RP with macular hole and normal vitreous pathology here. I did vitrectomy. The RP macular hole is settled after 15-20 days. You can see that the same area, the hole has closed. I left this vitreous here because there was strong adhesions here. And post-op, you can see that this vitreous is getting detached. So I think this would show us more about vitreoretinal anatomy. Now, this could be better than intraoperative OCT. This is a patient of PDR, which I'm going to operate this the OCT through this region, where you can see the abnormal vitreoretinal adhesion here. To this region, you can see that there is a more broad-based adhesion here, whereas here you can see that the adhesion is not. So there is a potential plane. Here again there is a potential plane. Here again over the macula, this region there is a lot of space here, and when you go superiorly, there is the macular area and there is a superior area. Compared to intraoperative OCT, this big swept shows, I think this would have better resolution and you can plan your surgery well in advance. So to conclude, I think swept shows, since it's a swept shows OCT, it has better penetration than spectral domain OCT. Advantage is that you can do the OCT anywhere to equator and also possible to do through gas filled eye. The color picture may not show much detail, but OCT does come well in majority of cases. So it will help us in understanding pathology of the disease process, what we were not seeing earlier. So this technology, I believe, uncovers the undiscovered retinal lesions, and it will open up your avenues of treatment because you are able to document things so well. Thank you for your patience.
That was a wonderful talk, Dr. Vatsal. You're truly wonderful. The colored photographs really made it appear so easy. I have a very basic question which I'm going to ask Mudit, and I should be allowed my ignorance. But the things like motion artifacts and some ciliary, papillary shadowing and all that, would not there be some challenge in getting this wild field fundus imaging?
So as far as the imaging, I'm sorry, yes. Sir, you were saying something, please go ahead.
Yeah. See, as far as this is a wide field photography, this is covering more than 200 degrees of the retina. So your eyelashes and eyelids would come in the view. So obviously for presentation, we have selected based off images, but there's a little learning curve, and with that probably can reduce a lot.
Okay. Yes, Dr. Mudit?
Yeah, the same point which sir was saying. Basically, as far as the imaging is concerned, even for this ultra wide field imaging, while Optos does allow us more than 200 degrees of visualization, the problem that sometimes happens is that the eyelashes tend to obscure the view. So you end up having a lot of these photographs where you see these inferior eyelashes or the superior ones. And what happens is that if it's a superior photograph, the ones which will be obscuring are the inferior eyelashes over there. So one of the ways is it basically the learning curve while you're taking those images. Sometimes you can use a tape to put upon the eyelashes so as to ensure that it does not come in the field of view. But it is predominantly more of a learning of how you're taking those images. But even with those eyelashes, even apart from that also, the field of view which you get in a lot of these images is pretty superlative. So that usually does help in uncovering and imaging a lot of pathologies, which we earlier were not imaging.
I think I agree with what Mudit sir said, but sir, now, taping we have tried it with our Daytona machine. The
Yeah.
patients experience a lot of problem and they do not concentrate and they do not fix it because of the probably the dryness they develop very soon. So I think the technician should be taught how to just separate the eyelids. And I think that will come away with most of the eyelashes. But whatever said and done, I have still seen with the best of the technician, we still see some of the eyelashes, and it's really worrisome. Vatsal sir, which machine is this? Is this the Optos, the Silverstone, or which machine you are using?
The Silverstone machine. This is the Silverstone.
Yeah.
So it has the capacity of Svetso's OCT.
Okay.
Coming on the eyelashes part, we have tried all this because we have this machine for more than 2 years now. I think dryness is most important, as Sriva said, when you are tapping the eyelids. But once when you take 3-4 pictures, probably patient gets used to it and it does not tend to close the eye. So probably he's much better. It's question of some learning curve, but it can be avoided almost 70% of time.
Dr. Barbara, you have to say something?
Yes, I would like to comment on wide field imaging. Well, first of all, just to compare machines, the Zeiss Clarus does not have this problem with the 12 and 6 o'clock eyelashes because the way of taking the picture is completely different. So it's not common to all wide field machines. And then I would like to add that the main advantages that I found in OCT wide field in the periphery as well as color pictures is not just to be able to see this lesion, but first of all, to archive the lesion because you see them and maybe at the follow-up, you don't really remember the details. And when you compare picture to pictures, it's much easier. And second is much easier to find the lesion through the picture instead of contact lenses because the compliance of the patient is much higher. In pediatric cases, it's much easier. You can take pictures of the fundus even in 2 years old or 3 years old baby without using any sedation. That's marvelous. And in most of the cases, the OCT can see lesions that you cannot see with the fundus view. Small, shallow retinal detachments. It happens to me in quite a few patients. So I really think it adds more than our visualization with contact lens.
Dr. Jatinder, one brief question. We'll go on.
Dr. Barbara has already answered. I had a few comments to make.
I can add Chitra for a minute.
Yes.
Can I add Chitra?
Yes, yes.
I think what Dr. Barbara said, in fact, we are making a routine practice to take photographs of all patients because, as I told you, the contrast is better with this photograph. So many times we have seen that we have missed lesion clinically, and when you see the photograph, you see that there's a horseshoe tear or there's some lesion, and you go back and see patient again, and you will find the lesion there to be there. Like the last photograph of macular hole which I showed, nobody would expect horseshoe tear. And that patient had choroid tessellation. So when we took photograph as a routine, we realized. So I think what point she drew was very important.
Yeah.